Hi, everybody. Oops. Let me see if I have my volume up. I did not want to comb my hair, but those of you that know me know that it's just one of the things I don't want to do sometimes, okay? So the hair is here. I'm hairing right now, okay? All right. We are live. I have the volume up as high as it goes. I need some words in the chat. Let me know that you can hear me. Can you all hear me? Yes. Hey, girl. Hey. Yes. Okay. So this is the first time I'm doing live on YouTube. And okay, we're just gonna see if this works. Okay. Hang in there with me. Let's just, see what we can do. Let's do what we do. I miss you all too. Can't say I miss Chamberlain, but I miss you all. Okay. Can I show something? How do I show stuff? Let me see if I say edit. No, that's not it. Look here. Oh, share. Hello. No, that's not it. Pop out dashboard. Is that it? No. I'm trying to learn as I go. Okay. While we're getting started talking about pharmacology, sometimes it's best if I just talk if I can't pull PowerPoints up, because you all know I don't like PowerPoints anyway. But, as I get this going, I might have a whiteboard because I have a school in Lawrenceville. So doing painting and getting the school together. So it's a CNA school. So once I get the school up and running, the new location up and running, the school is already approved by the state. But once I get the school up and running, the location, then I'll probably do things from the whiteboard and, all that fancy stuff. So I know that you all are doing, hey, Shikari. I know that you all are doing cardiac, which is my favorite subject, and respiratory. So throw questions in the chat, and I don't know how to pull up the PowerPoint, but I don't like PowerPoints anyway, so I'm just going to teach. I'm just going to talk to the PowerPoint. Even though you don't see it, I'm going to talk about it, okay? All right. Now, here's the thing. This is what people always worry about when it comes to listening to professors, and you don't know if, what if they're not teaching that at my school? And I'm saying this just in case someone sees this YouTube down the line. What we're talking about today, just in case somebody that's not a Chamberlain student sees us down the line, we're talking about cardiac drugs and respiratory drugs, okay? And I'll be doing these often. I will post different things, videos. I don't know what they're sharing at your schools, and that's irrelevant. Let me tell you why. Because at the end of the day, cardiac is cardiac. No one should be teaching it different. Now, it may be, well, what do we need to know? And I don't know if that's going to be on the test. Well, I know that now that's not even a factor. It's not about what's on the test, because they don't even tell the professors what's on the test. So now it's more about, okay, y'all know me. I got to turn the fan on because I'm having a hot flash. Now it's more about knowing the drug classes. First of all, it's always been about knowing the drug classes, but we would try to give you all focus stuff so that you all could pass the exams. Not that we were teaching to the exams, but we wanted to narrow it down because it's just a lot, right? And I get it. As a student myself, I get it. I know that when someone gives you too much, you don't know what to focus on. And what if you focus on stuff that's not even on the test? So that's hard. So I'm going to keep it very general. That means anybody from any school could look at this. I'm going to answer any questions you all put in the chat, any concerns, any confusion. And since this is my first one, we're going to work out the glitches, do what we need to do, and it's going to get better from here, because even though I left you all, I have never or will never leave you all. I'm always here. You got me for life. I'm your professor for life. Okay. All right. Let's start off with just some general stuff. Okay. And this is how, when I teach, I always used to start off like this too. So if you just talk about general stuff when it comes to the heart. Okay. So the first thing you need to know is the blood flow of the heart, right? And I miss you all too. The blood flow of the heart. So, and we all know this. I'm not going to go over this. This is more of a patho thing. So I don't need to go over the blood flow of the heart, but we basically know, it's coming in through the right side and it's going through the atrium and the, all of that stuff, and coming out in the left ventricles and atriums, and going into the right, coming out the left, right? The left pushes it out to the body. We remember that from patho, right? Patho is key. If you find yourself struggling with pharmacology, go back to your patho book, because it's going to help you with understanding how the body works, because that's all drugs are. Okay? I always start off my talk like this at the first day of pharmacology is, the body is beautifully made. Okay? It's made to fix itself. But because of circumstances, maybe it's the diet, maybe it's genetic, which means hereditary, diet, the food we eat, the lack of food that we're not, the vegetables and fruits that we're not eating. Just so many different things could cause cardiac issues, right? Sometimes we could be born with cardiac issues that manifest later on in life, like a murmur, a heart murmur. We've seen athletes fall out, right, from heart murmurs when they are in high school and they're working at their highest level. That murmur comes into play, where it didn't come into play when they were younger, but they've had it since birth. Okay, so certain things happen in your life that could cause you to have cardiac issues. I'll just use me as an example. I'm not claiming anything, okay? But of course, I have high blood pressure. I don't like to claim stuff because I'm losing weight. I know my face looks huge on here, but I have actually lost 40 pounds. So sometimes your diet can cause the things that were already in you genetically to come out. Okay? So just using me as an example, it runs in my family, cardiac issues. So if I wasn't going to eat right, if I wasn't going to keep my weight down, then it was bound to happen to me. So what your body does is it compensates when it first starts happening, right? You all learn this in patho. If you haven't taken patho yet, read up in patho about compensation. So when something's wrong with your body goes, uh-oh, what's going on? Wait a minute, what are we doing? Let me try to fix it. Right? It'll try to fix it. And then when it can't fix it, it breaks down. When it can no longer fix it, or it's been doing it for so long, it's run out of air, right? It's run out of steam. So when that happens, what your body does is it manifests signs and symptoms. So they say hypertension, silent killer, because there's really no real signs and symptoms, but other things will start happening, right? Other things will go wrong. I remember the first time I found out I had high blood pressure. I knew a lot of stress was happening in my life and everything. Once again, and it was hereditary, because a lot of people in my family have high blood pressure, right? Plus, I had gained a lot of weight, stressed out. But one day, I just felt weird. I can't even explain it. I just felt weird. There's no other way to explain it. It wasn't, some people say, oh, when your blood pressure is high, you get a headache. Well, that's not everybody, right? I didn't have a headache. I just felt weird. So I stopped at Publix grocery store and checked my blood pressure. Maybe it was the nurse in me. I don't know, but I just felt weird. 180 over 100. That was the day I found out, oh, girl, your blood pressure high. Okay. So Fast forward to today, when I started losing weight in September of last year, slowly losing weight. As I started losing weight, all kinds of things started happening. I got more energy. My blood pressure doesn't get high anymore. I still take hydrochlorothiazide, which is the water pill, right? It's in that family of diuretics. I still take that. That's usually the first line of drugs that they give you for hypertension. So I still take that. But it is starting to fix itself because I've lost a lot of weight. So I just gave you a background, little patho. That's all I was giving you to show you how things happen inside the body that can make things happen with your heart. So when you know that, you all listen to me. When you know that, now you know how the pills work, right? So for instance, I gained weight, probably was holding water. So the first pill they give you is something to get rid of weight and water, hydrochlorothiazide. So when you are talking about drugs, when you all are learning about drugs, this is what I want you all to remember. What does the drug do in the body? What's the purpose of the drug? What's the purpose of the drug? Why is this person taking it? So when I can tell you what the purpose of the drug is and why this person's taking it, now I can tell you the side effects. Okay, so Celeste is taking hydrochlorothiazide to get rid of her high blood pressure, which means they want her to drop some weight and get rid of the water. And they want her blood pressure to lower because of it, right? So what are my side effects? Put them in the chat. Come on, let's talk. Don't just listen. Put them in the chat. What are my side effects if I'm taking a drug that's going to lower my blood pressure? What are my side effects? Put them in the chat now. Let's go. Get the fingers ready. Okay. What are my side effects? Hypotension. There we go. Mag said dizziness, because you don't just say hypotension. What does hypotension look like? Right? Dizziness, confusion. Maybe you're even a little sleepy, you feel a little weak. Those are the things that you see on exams, not just hypotension, right? What does hypotension look like? So now that I know that, I know the signs and symptoms of that drug. Any cardiac drug that lowers your blood pressure is going to cause possibly hypotension. The goal is to get you to a point where it doesn't cause hypotension, it manages your blood pressure. But that's always an adverse effect that we tell our patients about to be wary of, because it's something that could happen. I'm dropping your blood pressure, so I may drop it really low. Okay, that's just a little background. Now let's get into, as I teach people. Too bad I don't have you all for pharmacology. I was very sad that I had to leave you, but had to go. Okay. But every time I stayed, I thought about you all, like, I can't leave. They need me this session. Okay. I'm not going to be looking in the chat for a minute because I'm looking at the slides. Okay. So when we're talking about cardiac drugs, we're talking about several drug classes. Adrenergic drugs, okay, beta blockers, ACE inhibitors, ARBs, calcium channel blockers, and I don't think you all are doing diuretics, but let's just talk, because remember, I'm doing this video for anybody. Diuretics and vasodilators. Those are typically your cardiac drugs, which means if you have a cardiac issue, any one of these drugs could be prescribed, okay, from one of those categories. So let's talk categories. Let's talk the first one. So let's talk our adrenergic drugs. We have peripherally acting and central acting. Remember, this is a YouTube, so I can't go too far and long like we're in class, okay? But there's centrally acting and peripherally acting adrenergic drugs. Okay? So, peripherally acting means these drugs do just what they say they do. They act peripherally, right? Peripherally. Okay? Centrally acting drugs mean they act centrally. They affect the central nervous system. So if there's a drug that's going to cross the blood-brain barrier, because not all drugs do, this would be the drug. Okay? So let's talk centrally acting first. Okay? So we talk central and peripheral. We're still on adrenergic. Okay? Centrally acting drugs like your clonidine and your methyl-dopa. I'm not going to go through all of the drugs, okay? But your clonidine and your methyl-dopa, those which are not typically your first-line drugs, not at all, but these drugs have weird adverse effects because they affect the brain, centrally acting, think central nervous system. So they could cause you to be dizzy faster. They could cause a real drop in hypotension, a real drop in your blood pressure, and they could cause orthostatic. So you're laying down, and as soon as you sit up, you go, whoa, your head swims because they're centrally acting. Okay? So usually when they use these drugs, your blood pressure is probably not controlled, and they have to add it with another drug. Now, methyl-dopa, can someone tell me what methyl-dopa is specifically used for? Methyl-dopa, anybody remember? Yes, Olivia, yes. Pregnancy, yes. And Kaylin, yes, I will link the slides down below. Because even though I use them at I'm gonna stop saying the name. Even though I used them at that school, I made them. Okay, they're mine. Okay, anyway. Yes, pregnant women. So think methyl-dopa. So why would I give a pregnant woman? How can I remember that without trying to memorize stuff, right? If it's a drug that, and this may sound bad, but I'm giving you all a way to remember it, okay? So just go with me. I'm trying to help you all so I'm in your head when you're taking the test. If I'm going to give a pregnant woman a drug for her blood pressure, okay? I don't really want it to affect the baby because remember, we don't want to give pregnant women anything ever, right? But if you have high blood pressure, you will die if we don't give you something. And we can't have the mother die, baby die, right? So I have to treat the mom. So the reason I'm giving her methyl-dopa, and notice it's not in your books written like this, but this is to help you remember it. If I'm thinking about something centrally acting, look at it like this. Okay, I'm messing around with the mama's brain. I'm not really messing around with her body. So it's okay to scramble her head as long as I don't scramble her body and it bothers the baby. This is just a way for you all to remember this, okay? So methyl-dopa is a safer, we didn't say it was safe. No drug is safe for a baby, right? But it's a safer drug to use for moms that are pregnant because the truth is we have to control your blood pressure. You could have high blood pressure at 25, then you get pregnant at 30. Well, you still need to take your blood pressure medication. So we can't keep you on other things that are very dangerous to the baby that could cause birth defects. So they switch it to methyl-dopa. Okay, so that's your centrally acting. Everybody got that? Okay, let's talk peripherally acting. Okay, peripherally acting are your sins, your OSINs, sin. So doxazosin, prazosin, it's probably some other ones too, but doxazosin, prazosin, that's all I can think of right now. Okay. These drugs reduce peripheral vascular resistance. So they help lower your blood pressure by helping reduce the pressure in your arteries and your veins. Doesn't that make sense? Peripherally acting. So I'm thinking arteries and my veins that's running through my body, peripherally. Remember, centrally acting, central nervous system. Okay? So when you see doxazosin, prazosin, those drugs, think peripherally acting, the SINs, SIN. Okay. So because they affect stuff like that, the side effects for those drugs, which are kind of the same, think about if they are dilating the arteries and veins, it makes the blood flow easier, right? Because that's what they're doing. They're opening up the arteries and veins, making the blood flow easier. They're releasing vascular resistance, okay? And all of this is causing you to keep from having obstruction in your arteries and veins, okay? But because of that, it could cause orthostatic hypotension because it's going to drop it fast. It's going to open it up quick, drop it fast so that there's no blockage of the blood flow. Okay? Does that make sense? So it's really, if you think about it, they're kind of doing the same thing. They're just doing it in a different way. The central acting, doing it in the brain. The peripherally acting, doing it in the arteries and veins. But ultimately, they're all lowering the blood pressure. How? By dilating the arteries and veins. Okay? Does that make sense? Because I want to get through stuff, so I don't want to spend too much time on stuff. Okay. Let's see. Okay, good. Okay, beta blockers. Let's talk beta blockers. Did you all learn? Have you all learned? Is it in your book? The 6 Bs for the side effects for the beta blockers? Okay, if you've learned the 6 Bs, if you've seen it in your book, if they told you, Christine, please tell me that. Okay. Oh, Lord, we're in trouble. Okay, so, all right, the 6 Bs. Okay. Oh, Lord. Okay, bradycardia. You all, somebody type it in the chat as I'm saying it. Bradycardia. B for blood pressure. B for boys. It's the 7 Bs. Well, really, we do 6 Bs. We do 6 Bs, okay? So B for bradycardia because it causes slow heart rate, okay? B for boys. We say boys because it causes erectile dysfunction. Okay, what are my other ones? Oh, B for blood glucose because it masks signs and symptoms of low glucose. So if a person has diabetes and they're on a beta blocker, we tell them make sure you check your blood sugar because if you get low, this medication could mask it. You may not see the signs and symptoms. Okay, everybody got that? Bradycardia, boys, which is erectile dysfunction, blood glucose. Okay, I'm trying to remember all of them, you all. Let me see. My brain. Let me see if I got it written down somewhere. Oh, bowels. It slows down your bowels. So you may have constipation. So there's your 4. I believe it's blood pressure because it's hypotension. So it lowers your blood pressure. We're talking about adverse effects of beta blockers. And the way to remember it, I'm giving you 6 Bs. Okay, that's what I'm saying, just in case anybody's not following me. I started off with bradycardia. That's an adverse effect. Boys, which is erectile dysfunction. Blood glucose, which is it masks the signs and symptoms of somebody's blood sugar dropping low. What else did I say, y'all? Ooh, I wish y'all were in front of me so I could talk. What else? Okay, yep, constipation, bowels. There we go. Thank you, Olivia. And blood pressure. And then there's another one. Oh, gosh. It's going to come to me. It's going to come to me, you all. Usually I would write this on the board and then I could see it. Okay. There we go. Bronchospasms. There we go, Katie. Bronchospasms. Okay. So let me tell you about beta blockers. Bronchospasms is the 6th B. Bronchospasms. Katie just put it in the chat. Okay, so here are beta blockers. Beta blockers work like this. Remember, if I tell you how a drug works in the body, you should be able to understand the adverse effects. Okay, so beta blockers work like this. They work by attaching to the beta receptors in the heart or the lungs. So there are certain drugs in this class. One is beta 1, and some drugs are beta 2. The beta 1 drugs work directly in the heart by attaching to the receptors in the heart and slowing things down. That's your bradycardia and your erectile dysfunction. They're slowing things down to help slow down the demand for your blood flow or heart rate, right? So that now the blood can pump a little more efficiently and we can lower the blood pressure, okay? So drugs that are in beta 1 affect the heart. Drugs that are in beta 2 affect the lungs. We have one heart, we have 2 lungs. That's how you remember it. Beta 1 heart, beta 2 lungs. So when the drug is working in the lungs, same thing. It's attaching to the receptors and it is helping it slow down, right? So that you can lower your blood pressure. Heart, lungs, all work together. That's how that makes sense. Remember, we talked about the blood flow. You all know this. Heart and lungs work together. Here's what you have to remember. And hopefully you all have talked about this in class. If not, it's in your book, whatever book you have, okay? Is certain drugs, beta blockers in general, we have to be careful when a person has asthma or COPD. When a person has asthma or COPD, it's not good to give them a beta blocker. Now, if the drug is just a beta 1, we could be a little cautious about it. But if it's a beta 2, it's contraindicated because it could cause bronchospasms. We don't want to cause bronchospasms in a person that already has asthma or COPD that's struggling to breathe. Does that make sense? All right, we're going to move on to the next one. I'm going to have to do this a little more often for you all because I know you all have exams coming up. So I'm going to try to do this a little more often so I can help you better, longer. Okay? All right, so that's beta blockers. Now let's talk about ACE inhibitors. ACE and ARBs. I used to tell you all, when I used to teach this, I used to say they're cousins. Not sisters, they're cousins. They do the exact same thing, but they're in different households, so they do it slightly different, okay? So ACE inhibitors, ACE stands for Angiotensin converting enzyme. So if you all remember in patho, what happens in the kidneys? Angiotensin 1 turns into angiotensin 2. And when that happens, a potent vasodilator is released, and that dilator helps absorb some of the sodium in your body. And that's a good thing. That's your body just doing what it does. It's maintaining homeostasis, right? We can't pee out everything and get rid of all the sodium, and we can't do that. We have to live. Our body and our cells need sodium, water, potassium. It needs all of that, right? So our kidneys know how to flush and then still keep what it needs. Okay, that's patho. If you need to understand that, go back to patho. So with ACE inhibitors, it's an angiotensin converting enzyme. So what the ACE inhibitors do, and that's your prils, okay? Everybody remember that, hopefully. Your prils, P-R-I-L, lisinopril, captopril, all the prils, okay? So what this drug is doing is when you take this drug, it is keeping angiotensin 1 from converting to angiotensin 2. So Christine, those are ARBs that you're talking about, Christine. ACE inhibitors prevent angiotensin 1 from converting, hence the name angiotensin converting enzyme. So angiotensin 1 does not convert to angiotensin 2. That way you can release more sodium, because that's one of the problems of somebody with hypertension. We need to get sodium and water out. So by blocking that, it'll help you release more of your sodium and water. You're not going to release all of it, right? Your body's not going to allow that to happen. You're not going to become dehydrated. But we are going to allow, what it does allow is you to release some of that. Yes, it causes vasodilation when that happens. Absolutely, Sharon. Because angiotensin 1 converting to angiotensin 2 causes vasoconstriction. Okay. Now, what Sharon Christine was saying are ARBs. ARBs help, and here's what they stand for: angiotensin receptor blockers. There you go, Christine. The name says what it does. So angiotensin 1 is blocked at the receptor site. So in essence, it's doing the same thing as the ACE inhibitors. It's just stopping that whole process, angiotensin 1, angiotensin 2, vasoconstriction, all of that stuff that's happening in the kidneys, and helping you keep some sodium. Whether you're taking an ACE or an ARB, both of them are helping you get rid of some of that sodium and water. All right? So now that you know that, what are the adverse effects? What could be caused? Just think of basic. For either one of them, what could be caused? What could happen? Just real general. What could happen with this? Okay, so Christine, angioedema. Okay, there we go. We'll get back to that, Christine. So very general, ACE and ARBs, hypotension, right? And possibly hyperkalemia, right? Because sodium is leaving. When sodium goes down, in essence, when sodium goes down, potassium goes up. Remember, we learned that in patho. So that's your very basic adverse effects. And it doesn't happen as often in the ARBs. So now let's talk very specific adverse effects that you would have to look up. You wouldn't know unless you just know. So for ACE inhibitors, the classic sign and symptom, or adverse effect, classic adverse effect is that dry, irritating cough and the possibility for angioedema. So that's what you were saying, Christine. That is mainly in the ACE inhibitors, lisinopril, captopril, that's all the prils, okay? Enalapril, benzapril, all of the prils. But if you want to talk ARBs, ARBs are less likely. Remember, they're cousins. They're not sisters. They don't do the same thing. So when you take an ARB, even though it is in essence doing the same thing, it's blocking that receptor so that you can get rid of water and sodium. That's what it's doing. But it has been found, obviously, when they gave out the drug, they first created it, tested it, boom, great. Yeah, it's working. They realized it doesn't do as bad as the ACE inhibitors. So actually, the ARBs don't have as many adverse effects. Actually, if a person is on an ACE inhibitor and they're not tolerating it well, like they have that dry cough, their potassium is constantly going high, they'll switch them to an ARB, because ARB will do the same thing, but you may not have that hyperkalemia. You're not going to have the cough. That does not come with an ARB, okay? And then hypotension, that's all these drugs, okay? That's all of them. So your ARBs are your sartans, SARTAN. That's how you recognize the ARBs. So the ACE inhibitors, just for me to give a recap, ACE inhibitors, your prils, lisinopril, captopril, enalapril, benzapril, the classic adverse effects, dry cough, hyperkalemia, and angioedema, swelling of the tongue. Okay? Your ARBs, cousins, they're cousins, not sisters. They do the same thing pretty much. But ARBs, not really many adverse effects, may have an issue with potassium, may not. Hypotension, yeah. And those drugs are your sartans, losartan, valsartan, olmesartan, all the sartans. Okay? You all got that? Let me see if it's anything else about the ACE and ARBs. Oh, neither one of these drugs classes. These are neither one, your ACE inhibitors, your ACE or your ARBs. Neither one of these is good for pregnancy. Neither one of them. They could cause birth defects. And you do have to monitor the kidneys. But I hope you all are learning in pharmacology that no matter what drug you're on, you probably need to look at the kidneys. Some drugs more than others because they purposely damage the kidneys. But to me, it makes sense that this drug, I would monitor the kidneys. Why? Because it's directly going into the kidneys and stirring up a mess. It's blocking stuff. It's stopping the kidneys from doing what it's supposed to normally do. So, of course, you want to monitor the kidneys when you're on these drugs, ACE and ARBs, because that is what they're doing. They're going directly into the body and messing around with the kidneys. Okay? But, of course, drugs are excreted through the kidneys. All drugs, right? Everything we drink, eat, drugs is being excreted through the kidneys. So anytime a drug is toxic to the kidneys, you're always going to monitor the kidneys. But then when there's a drug that purposely goes in and messes with the kidneys, you're going to go and monitor the kidneys. Okay? All right. No real adverse effects for that one. So we've talked adrenergics, beta blockers. Oh, and beta blockers, I don't know if I gave you all the beta blockers are I call them the laugh out loud drugs. Okay. Those are the OLOLs. Okay. I call them the laugh out loud. Okay. That's your metoprolol. That's those drugs. Okay. The LOLs. All right. And we know that those adverse effects are the 6 Bs. Okay. Then we talked about the ACE inhibitors, purposely going in there messing with the kidneys and disrupting the sodium and the potassium, right? It's making the sodium get out the body. So it's increasing the potassium. And then one of those things that you just have to know is angioedema, and that dry cough is classic. Then the ARBs, not really too many adverse effects, maybe calcium, hypotension, but no cough, no really angioedema. Okay. All right. Calcium channel blockers. Okay. Let's see. ACE and ARBs, the beginning drug for someone with hypertension. Yes. Yes, they are. And that's because that's a good question, Christine. ACE and ARBs are usually the first line of drug that they give people when they are first diagnosed with high blood pressure. If they don't start them on ACE or an ARB, they'll start them on a diuretic, like me. So they'll start them on the hydrochlorothiazide. So in essence, what are we trying to do? What's the first thing we're trying to do? Get some of that fluid off of you. Get some of that sodium off of you. They'll tell you change your diet, stop eating so much salt, cut down on salt substitutes. Let's get rid of all this extra fluid because extra fluid raises your blood pressure. Let's get rid of that and see if that works. And if it doesn't, then we'll have to switch it because then something else may be going on. So it just depends on what's causing the high blood pressure. But for the most part, nothing's ever all, but for the most part, they usually start people off with either the hydrochlorothiazide, which is nothing more than a diuretic, a water pill, or an ACE or an ARB. Okay, so good questions. Okay, calcium channel blocker. Okay, calcium channel blockers do just what they say. So, what do we use calcium for? What is calcium used for in our bodies? What does it help do? Somebody throw it in the chat real quick. Calcium. Yes. Build up good bones. Yeah, relax. Yes, it does. It relaxes the heart. So in other words, it's the reason, first of all, your heart's a muscle, right? So it's the reason your heart pumps nice and calm, right? Right? So when there is an influx of calcium, your heart's going to start doing this. It's going to do this. And if it's doing this, no blood's getting out to the body. It's causing an increased demand in the work of your heart, which means my blood pressure goes up. So what I need to do is stop the heart from doing this. Okay? So if the reason is from calcium influx, then I'll give you a calcium channel blocker. What calcium channel blockers do, just like their name states, is they block an influx of calcium from coming in. And because that, they slow down the heart, the work of the heart. So now let's talk about CCBS. Let me type that in the chat. CCBS. That's the acronym to remember the adverse effects for calcium channel blockers. Does anybody know what they mean? Adverse effects for calcium channel blockers. CCBS. Okay, so the B stands for bradycardia, because remember what I was doing. I was doing this, right? So when you say, Sharon, rapid decrease in blood pressure, just keep that in mind. You don't even need to think of that. That's saying hypotension. Hypotension is an adverse effect. Oops. Hypotension is an adverse effect of all of these drugs. Okay, all of them. So let's learn the stuff that's not easy to remember. We know hypotension. So when we're doing this, and now I stop you, and we do this, I could cause bradycardia. I'm slowing down the heart. Yes, Shakari. So because I'm slowing down the heart, slowing down the body, slowing down the pumping of the blood getting to the areas it needs to get to. And when it doesn't get to the areas it needs to get to, or it's not enough of it to get to the areas it needs to get to, some areas suffer. Oh, we don't care about those intestines. We need to get blood to the brain and back to the heart and to the lungs. So who cares about those little intestines? So constipation is one C. Absolutely. The second C, you just may or may not know. So I'll just tell you, complete heart block. So it can completely stop the heart. So constipation, complete heart block. The B, we already said, that's bradycardia. And the S, because the blood is going so slow, it's pumping slow, it could start to pool in our lower extremities. And because of that, it could cause edema. So the S stands for swelling. So constipation, complete heart block, bradycardia, swelling. All that other stuff you all already know. Oh, hypotension, dizziness. Oh, you all already know that. You don't need to keep studying that over and over again. That's the easy stuff. Of course, a blood pressure med could cause hypotension. You need to remember the stuff that you wouldn't know unless you looked it up. Some stuff will come back to you because you'll start to remember what the drug does in the body. Some stuff like dry cough. Okay, I just need to know that because what does that have to do with a blood pressure pill? So I just need to know that. Okay, so that's your calcium channel blockers. Everybody got that? All right, moving right along. That was calcium channel blockers. Now, calcium channel blockers. Your amlodipine, your cardizem or ditalizem, I should say that, verapamil. I know those don't look alike or sound alike. So those are drugs you're just going to have to remember because all of those don't look alike or sound alike. like the ACE inhibitors and the ARBs, you know, all those drugs look alike. Okay. Vasodilators. This is the easiest one, you all. Vasodilators. You know why it's easy? Because they do just what they say they do. They do what their name says. Vasodilate. So when you're talking vasodilators, you're talking about hydrolysine, nitroprusside. Okay? Those are your vasodilators, which simply means they vasodilate. They open up the blood vessels, arteries, veins, and when they open up, that makes the blood flow smoother. That lowers your blood pressure. It lowers the decrease in the demand on your heart, all that good stuff. So you may have a person that has a cardiac problem that's on a vasodilator, or a person that has high blood pressure that's on a vasodilator. Okay, so vasodilators, easy peasy. Okay, let me see. Is there anything I want to tell you? Today was just cardiac, because I just really didn't, you know, I don't want to do too long on the video, because then it's like overstimulating. Okay. Let me just make sure I covered all of my... Oh, diuretics. That was the last one. Okay. So remember I said I was going to cover just basically the adrenergic drugs, beta blockers, ACE, ARB, calcium channel blockers, vasodilators, which are simple, just simple to the point, and now diuretics. So last 10 minutes, I'll do diuretics. I know that's not long, but let me just say this about diuretics. What do diuretics do? They make you pee. That's what... So you may be on them for different reasons. Different people are on them for different reasons, right? It could be for high blood pressure, like me. Remember I told you I went to the emergency room, 180 over 100. They gave me hydrolysine to get me down fast, because that's what hydrolysine will do. It'll get you down fast. Okay. But then they put me on the... Yes, Milrinone. Yeah. They put me on the hydrochlorothiazide just to get rid of the fluid as a long-term solution. Okay. So sometimes people have edema for certain reasons or another. You know, it could be heart failure. It doesn't always have to be blood pressure. And they may be put on a diuretic. Okay, I'm trying to get to the diuretic chapter. Okay, diuretics. So there are several types of diuretics. I don't want to go too deep into all of them, but there's loop, potassium sparing, and thiazide. We won't talk about the osmotic. Osmotic is for swelling in the brain. That's mainly what that one's for. So what you will see someone on that maybe has high blood pressure or heart failure, or just maybe on a diuretic for something else, they'll either be on a loop, a potassium sparing, or a thiazide diuretic. Okay, so your loop diuretic, you all should be very familiar with loop diuretics, maybe or maybe not. These all end in IDE: furosemide, torsemide, bumetamide, IDE. Those are your loop diuretics. And you know why they call them loop? Keep this in your head. Because they're in the kidneys, messing around in the loop of Henle, in the kidney. That's why they call them loop diuretics, because they are in the loop of Henle inside of your kidneys, messing around with stuff, trying to get you to get all of that water out. So same thing with the ACE and ARBs as far as adverse effects, right? First of all, with these drugs, even deeper than the ACE and ARBs, it actually messes up or causes an imbalance in your electrolytes. Sodium goes low. For potassium also goes low. Potassium goes low. Sodium goes low. Because remember, we're used to hearing, oh, where sodium goes, potassium goes the opposite. Not in this case. In the loop of Henle, these drugs in there messing around, and they causing all kind of disruption to your electrolytes. So they're causing your sodium and your potassium to go low. They're not potassium sparing drugs. Potassium sparing means drugs that help you keep your potassium. Loop diuretics are not potassium sparing. So you have to check someone's potassium level because they could drop it really low. They're like disrupting all of your electrolytes. So when somebody is on furosemide or any of the loop diuretics, they're very potent. They could drop, you could lose 7 pounds in 2 days on the loop diuretics. They're just that potent as far as getting rid of water. Okay, which means they drop electrolytes fast, right? It may start off with, oh, a little sodium's going, so much potassium's going up, but then they're just going and going and going. It's like, okay, wait a minute, now you're getting rid of all of us, okay? So the loop diuretics, Sarita says she need them. Girl, go to the doctor and lie. No, I'm just kidding. Don't do it. Don't do it. Like, oh no, my blood pressure high. Can I get some of that loop of Henle stuff? Don't do it. Don't do it. Okay. So people will lose weight. They will have iron imbalance. They become dehydrated. Hyperglycemia also happens in these. So you have to watch for that because remember, it's just in there just messing up some stuff. It's just messing up all your electrolytes, all your sugars and your potassiums and your everything. Just that's what you remember about loop drugs, your furosemides, torcemides, butamides. Those are your loop drugs, loop diuretics. Okay, the next ones, potassium sparing drugs. Now we're talking about drugs that spare potassium. So because they spare potassium, what is our concern? What's our concern with these drugs? They're keeping in. Normally, what's supposed to be happening is we're supposed to be getting rid of everything, right? Not hypo. They're potassium sparing. There we go, Sarita. So we're keeping in the potassium, right? Potassium sparing. So we have to watch for hyperkalemia, headaches, dizziness, fatigue, cramps, because it's getting rid of the sodium, but the potassium is going up. Yeah, heart palpitations, all of that. Anything dealing with high potassium levels. Potassium sparing. How do you remember this? Spironolactone. Just think of spiro as spare. That's how you remember that one as the potassium sparing drug because it has spare in the word, kind of. It's not spelled the same way, but spironolactone. That is the potassium sparing drug. So it increases it. Whereas the loop diuretics decrease potassium. So either way, I don't care what drug I'm on, I need to monitor the kidneys. I need to monitor the electrolytes. I need to monitor INOs. I need to do that with any diuretic that I give my patients because I'm purposely making you get rid of water. Drugs, I'm trying to say this nice because it's on YouTube. Drugs go in the body to disrupt things, to fix them. Okay, so we have to keep an eye on them. We have to monitor our kidneys and our body because they disrupt things. You know, because the drug people, the pharmaceutical companies is, shut me down. Okay, your thiazide-like diuretics. So just remember me, the hydrochlorothiazide, Metolazone is another drug that is in that category, but it's usually the drugs that have the thiazide in the word. Okay. These drugs also deplete potassium. There's only one diuretic that's potassium sparing, and that's spironolactone. That's the one you see them give kids most of the time, the potassium sparing drug. Okay. Or somebody that has cardiac issues or something like that, but they give spironolactone to children for the most part, not all the time. But if they need a diuretic, that's usually the drug of choice. So here we go. 3 types of diuretics. The loops, your furosemide, butamide, all the IDEs, they get rid of potassium. The thiazide-like drugs, metolazone, as well as anything that has thiazide in it, hydrochlorothiazide. Okay, that's your thiazide drug. They also get rid of potassium. Okay, you all following me? The only one that spares potassium is spironolactone. Okay, are you all with me? And I know that was just like a rough draft of cardiac drugs in general, drugs used in cardiac. And I'll try to do another one, but I will post this down below. If you all have any questions, you can put them in the chat. I'll come back to them. If you all want me to do a certain video, put that in the chat. What were the adverse effects for loop? Potassium depletion. Okay, so remember, potassium depletion. So if I'm getting rid of the potassium, my potassium is dropping. That could cause a heart attack. See how when you know what a drug does in the body, you can start thinking of the adverse effects. See what I mean? Yes, I'll post the respiratory slides as well. I didn't want to make this long, so I had to decide to do between cardiac and respiratory. Cardiac was the more difficult or more challenging subject. But let me tell you all this about respiratory, just really quick. I'll post some respiratory stuff, but let me tell you this about respiratory. There's only a few reasons you're on respiratory drugs. You can't breathe. That might be the only reason that you're on respiratory drugs. You can't breathe. Okay. So if you can't breathe, I need to help you. I need to open you up. Okay. I need to open up the bronchioles, open up the alveoli, not the alveoli. Those are at the bottom. What is that called, you all? I can't even think of it right now because my brain was on cardiac, but it is used to open you up. So let me tell you, the best drug, the most important drug in respiratory is albuterol because it opens you up fast. But one of the adverse effects of albuterol is hyperactivity. It could cause anxiety, panic attacks. When you give it to little children, they fly through the house, little kids that may have asthma and they have to take it, tremors, that, bang, zoom, they're all over the walls. It calms down eventually. But that is the drug that is used to rescue someone. So if I'm struggling, I can't breathe, I feel like my airway is closing, albuterol, inhaler, albuterol, a nebulizer treatment, something to open me up fast. If I'm having troubles with COPD, I'm having asthma, I have, long-term asthma, I need drugs that will help me every day, which are called maintenance drugs. That would be your corticosteroids. Those are drugs that keep you open. They don't open you up like albuterol. That's why that's the rescue drug. So if somebody's struggling breathing, you grab that rescue inhaler. You don't grab that corticosteroid inhaler. The corticosteroid inhaler is used to give you maintenance, just keep you open every day, decrease inflammation, keep you open so that you have better quality of life when you have asthma and COPD. Okay. Whereas albuterol, you need that handy because just in case. And then maybe at night, I struggle to breathe. So I'll do a nebulizer treatment at night. But I'm putting albuterol in it. So anything that says albuterol, levoalbuterol, those are all in the same family. But albuterol is usually the one of choice. That's the drug of choice. Okay. So things like Montelukast, aka singular, that's usually taken at night. And it's a maintenance drug. And then any steroid is used as a maintenance drug. And just remember, when you do maintenance inhalers, steroids, white stuff on your tongue. So we have to tell our patients, when you do the inhaler, rinse your mouth out, clean your mouth out. Because if you don't, you're going to start getting that white film called thrush or candidus. Okay? People that have hypertension cannot take albuterol, correct? No, that's not true. Because remember, it may increase it for a moment because you will panic, it may raise your blood pressure, but eventually you'll calm down. It's not going to stay like that forever. It's just used to open you up real fast, so it causes the tremors real fast. Contraindications for albuterol? None really, unless you're allergic to it really, or I can't think of any, Ivana, to be honest with you. Check your book just to check behind me, but I can't think of any right now. Albuterol is a rescue drug. At the end of the day, we're going to bust it out. Epinephrine also, that'll open you up fast too. Restart your heart, If you're having like an allergic reaction, you get stung by a bee, boom, epinephrine, poof, it's going to open you up. You're not going to grab an albuterol inhaler. You're going to do that epinephrine. So unless you're allergic to it, or maybe it's some type of contraindication. So what I want you all to focus on when you're being tested, I don't care what school you're coming from, just in case there's other people watching this. Adverse effects come from what the drug is doing in the body. That's what you remember. So if you cannot remember 30,000 adverse effects for a drug, which you shouldn't have to, when you're sitting there and you're taking a test or you're taking care of a patient, say to yourself, okay, they just took a blood pressure medication. What could happen? First of all, if they swallowed it, it's going to go through first pass effect, right? So it's going to take about 30 minutes for it to take effect, 30 minutes to an hour, right? If it's an IV drug, either immediately or within the first 15 minutes, we should see some type of effect. So as a nurse, we know when we give somebody a drug, we know when we're going to watch out for something that may happen. One, anybody could be having allergy to something, right? The first time I take a drug, I can have allergy to it. So we always pay attention to that. Make sure the patient doesn't break out from a drug that they are taking for the first time. Okay, that's one. Second is, what does this drug do to the body? Oh, it's dropping the blood pressure. Okay, let me go back in there and check Mrs. Jones' blood pressure again, because this drug I just gave her drops blood pressure. So I need to check it to make sure, one, it did drop the blood pressure, because that's a therapeutic effect, but it didn't drop it too low, because that's an adverse effect. Okay, so just take your time, read the question, say to yourself, what type of drug is this? Even if I forgot if it's an ACE or ARB, what is it doing in the body? And then let me go from there as to what this drug may cause as far as an adverse effect. And then that should help me understand as a nurse, what should I be doing? What should I pay attention to? Should I go check their blood pressure? Do I need to go call the doctor? Do I need to get a rescue inhaler? What are the things that I need to do as a nurse? Because I just gave this drug and this could possibly happen. Or this did happen, so now I need to act. That's how you think of drugs, you all. Throughout the entire pharmacology course, that's how you look at drugs. They're getting it because something is wrong. So they swallow it, and I need to pay attention to what that drug may be doing. How do we know adverse effects? Because when the manufacturers made them in a lab, in a chemical lab, and then they put it out there in the world and people start taking it, then people start complaining of stuff. And they say, oh, they complain of headaches. We got to put that on the label. Oh, she complained of a dry cough. We got to put that on the label. So don't make these things bigger than what they are. Antiplatelets and anticoagulants, can't get into them because that would make us go really long, but the PowerPoint is going to have them. Antiplatelets, it's stopping you from clotting. Anticoagulants is preventing you from clotting again. Antiplatelets directly work into your platelet aggregation. They directly work with platelet aggregation. Anticoagulants work with your blood clotting, the time it takes for your blood to clot. That's just a basic. Antidysrhythmias or arrhythmias, same thing. Those are the exact same things. The big thing about those is just what they said. Now watch how easy those are. If I'm taking an antidysrhythmic, okay, if I'm taking a medication because I have AFib, right? My heart's doing this. I have AFib. So they're going to give me a medication that's going to slow it down. Well, if you give me a medication that stops me from having one dysrhythmia, the adverse effect is another dysrhythmia. That's basically what antidysrhythmics are. They're medications that are supposed to put you back into a normal rhythm. So if I'm AFib, you're trying to stop me and make me go back to sinus rhythm. But the problem is you may cause me to flatline. You could cause me to VFib, which is like flatline. You could cause me to flutter, right? So the adverse effect of any antidysrhythmic is a dysrhythmia. That's what it is. I'm taking a drug to get me out of the rhythm to put me back in normal, and it could cause another rhythm. That's the adverse effect. So once again, let's say there's specific adverse effects in the book for antidysrhythmics, and you're taking a test and you're going, dang, I don't remember which one. Let me close my eyes. I remember that if they're taking a medication for dysrhythmia, a dysrhythmia could happen. So now let me open my eyes and look at the option choices and go, oh, that's a dysrhythmia. That's the answer. This is how you make things easy and make them make sense. I know I'm saying it like it should be easy, but really, if you just relax, take your time, answer only what the question is asking you. You all know how questions are. They give you a big old scenario. Mr. Jones, he walks in the hospital and his blood pressure is this and his heart rate's this and his temperature is this, and it's like a whole bunch of stuff. That's just painting the picture. Then we get down to the actual question. What medication would Mr. Jones be expected to be put on for high blood pressure? Oh, lisinopril, because it's usually the first line. Okay, A. Now, it said all kind of stuff in the question, but it just really wanted to know which one is the first line of drugs that we give, ACE inhibitors. That's all it wanted to know. So make sure you're answering the question and not reading all into the scenario and trying to make something else happen. Okay? So I'm going to post the PowerPoints down below. Like I said, this was just the first time, so I was trying to get the kinks out. But now I'll know how I want to do this for you all from now on, and I'm going to post more videos. I may even do videos and then just post them. My study time with the professor videos that they may show you at that school that I'm not naming. But those are my videos. So I may post those because I have them. All right. Well, good to hear, Lauren. Hey, Desiree. To all of you, I miss you all so much. Highlights of my 9-year career at that school was the students. So I'm going to keep doing this for you all. All right. Take care, you all, and I will be posting it down below. Okay.